So let's move on to discuss how major neurocognitive disorders in general present in the clinical setting. It can be highly variable. It can be quite subtle, masked by a caregiver or living arrangement that may not expose all the deficits that a person may have. Most types are gradually progressive, and the onset is usually weeks to years after the actual cause of neurocognitive disorder. So let's talk first about cognitive symptoms of major neurocognitive disorders, which should affect any or all of the 6 cognitive domains defined by the DSM. Memory loss is the most common, but it can also affect language, social cognition, inattention, perceptual motor dysfunction, and executive function. There are also behavioral or neuropsychiatric symptoms of major neurocognitive disorders, and these are usually in 12 categories. One is apathy, which is the most common, depression, anxiety, hallucinations, delusions, irritability, agitation, disinhibition, mania, aberrant motor behaviors, and sleep and appetite disturbances. What about cognitive symptoms? So it depends on which part of the brain is affected by the disease, because each lobe has its own function. So as you can see in this simplified diagram, the frontal lobe is more concerned with executive functions, affect, social cognition, and personality. The parietal lobe is more focused on visual information processing, spatial orientation. Visual perception is the function of the occipital lobe, and the temporal lobe is where most of the memory functions are, language production and language comprehension. So cognitive symptoms, when it comes to learning and memory, anterograde amnesia is the most common. It usually affects short-term memory much more than it would do for the long-term memory. Difficulty learning new simple skills. So if you switch to a new TV, a new microwave, or a new phone, they have significant difficulty learning the new one. Forgetting to buy familiar items like grocery, missing bills and paying them after when they are due, buying the same items more than once. You go to the grocery store, buy something because they think it's missing from home, they go back and realize they already have it. Repeating questions over and over, which can be annoying to caregivers. They have difficulty recalling recent events or conversations. They may rely excessively on lists and reminders. They can mix timelines. They cannot really tell you a sequence of events properly, and they tend to misplace objects frequently. What about inattention? So tasks may take longer than what it used to be. They can get easily distracted by multiple stimuli in the environment. They have difficulty holding on information for calculation or manipulation. So you give them a simple math equation, they cannot hold the numbers long enough in their head to make the calculation or dial a phone number. Work requires more revision and supervision than it used to be, and they have difficulty concentrating or staying on task. They just get distracted. Language. Language, most common symptom is difficulty finding the correct word, difficulty naming objects and people, mispronunciation of some words. They may have some major syntax errors when they write or talk. They have difficulty understanding written and verbal communication in severe cases. Executive dysfunction. So that means that they may have difficulty completing familiar multi-step tasks. They may avoid house chores, especially cooking. They have difficulty planning, difficulty packing for travel, difficulty following a series of directions, difficulty shifting conversations, difficulty making a choice, and difficulty solving their day-to-day problems. What about perceptual motor, which means also visual spatial? That means that they get lost in familiar environments. It may show as difficulty using familiar appliances or tools, so they hold it and they do not know how to manipulate it properly. They may have difficulty driving and understanding directions. They may have difficulty gauging distances if an object is close enough or far enough. And that also shows when they try to put something together or draw on a piece of paper. Social cognition gets impaired, so they would make like gaffes or inappropriate behaviors. They may have poor judgment calls in social settings. They may have limited perception of social cues if somebody around them is annoyed or happy or displeased. And they have impaired empathy, so they do not react as they used to pleasant or unpleasant news. Let's talk about neuropsychiatric symptoms, which is a very important part of major neurocognitive disorders and a major cause of caregiver burden. So the first and the most common one is apathy, where they lose interest in the world. They lose interest in things that they used to enjoy. They do not maintain motivation to start new activities. They are much more difficult to engage in social settings, and they are less likely to initiate a conversation. It is very common in dementia and among the hardest symptoms to treat. Depression. They can get tearful, hopeless, acting in low spirit, feel like they are a burden and deserve to be punished. Sometimes it gets bad to the point that they have death wishes and think about hurting themselves. This symptom is usually more common earlier in the course of disease, especially if they recognize that their cognition is not what it used to be. Anxiety. Due to their awareness of the change in their cognition, they can get quite anxious, very worried about planned events, unable to relax even in usual pleasant settings. They can get panic attacks and get quite nervous when they are separated from their caregivers. Hallucinations. These are particularly more common later in the course of the illness. They may describe hearing voices or act as if they are hearing voices. They may talk to people who are not in the room. And similarly, they may see, smell, feel, taste things that are not there. Among all these hallucinations, the visual ones are particularly more common. Another concerning neuropsychiatric symptom is delusions, which are defined as false, fixed beliefs that you cannot refute despite clear evidence. So they may start believing that physical danger is imminent, that somebody is trespassing in their property, that their spouse are cheating on them. They believe others are stealing from them, especially when they misplace their objects too often. Instead of thinking, oh, I may have misplaced it, they would think, somebody's stealing from me. They may start thinking that family and their partner are actually imposters. Or this is not my home, I need to go home when he's actually at his residence. They may think that family will just abandon them and leave them in a nursing home and walk away. And sometimes they may start believing that the TV characters or the ones that you see in the newspapers are actual figures living or existing in their own physical space. And that could be also enhanced by how high definition the TVs have been recently. The content of the delusions in dementia tend to change from time to time because their memory doesn't hold on to the system that they have created for too long. Our next symptom is agitation or aggression, and that usually manifests in resisting doing some activities, especially taking meals, accepting medication, and bathing. They can get a little bit hard to handle, and caregivers would describe them as uncooperative. It can be verbal, and in worse cases, it could be physical. Next is irritability. And when we talk about irritability, we're more focusing about their mood, their temper, rather than their behavior. So With dementia, it can come in bouts. They can present as cranky and impatient, so they ask for example, to be fed or to go outside, and the caregiver would say, "Wait a minute, I'll attend to your needs," and they get immediately upset and angry. They cannot cope with delays. It may present as sudden flashes of anger that go away quickly, but may be happening too often and quite burdensome to caregivers. Next is mania, which is basically being too happy for no reason or laughing at things that are not actually funny. It may manifest as childish sense of humor or too giggly. Some patients may do some practical pranks on their family members or present as a bit grandiose. Disinhibition, meaning that they become a little bit more impulsive than their baseline, socially unconstrained, again, compared to how their character before the disease. They make some crude or sexual remarks to strangers, sharing very private matters with total strangers, and a tendency to hug or touch others without permission. Next is aberrant motor behaviors that are mostly increased motor activity that doesn't really have a purpose, including pacing, fidgeting, packing and unpacking either bags or drawers, increased rituals that again are purposeless, changing their clothes and outfits too often, picking on buttons, threads, and maybe items around them. In severe forms, it may show some wandering behavior where they decide to go outside and just keep walking. So the last two that we have to discuss here are sleep disturbances and appetite disturbances. So when it comes to sleep, they may suffer from difficulty falling asleep, nighttime pacing, waking up in the middle of the night thinking it's a new day and they are ready to go, or waking up too early in the morning thinking that it's 10 a.m. when it's actually 4 a.m., or excessive daytime naps. So when it comes to their appetite, they may show increase or decrease in their appetite, which could lead to some loss or gain in their body weight. They may show some changes in their feeding behaviors, in the way they manipulate their utensils, the way they choose their food, what type of food they're consuming. In severe cases, they might consume inedible stuff as food, like ketchup or wood splinters or pencils. And sometimes we see a change in their food preference, as in craving too many sweets, one of the more common ones. So after viewing several symptoms of major neurocognitive disorders or dementia, I invite you to take a deep breath and think which one of these symptoms might be the most problematic for patients, and which one of these symptoms might be the most problematic for caregivers.